Maybe you could share with the audience some of the ways that you're leveraging AI there at BINGLI.
You can leverage LLMs very effectively and ambient AI technology very effectively.
It's brought a lot of questions and concerns on the safety and efficacy of AI.
On the clinical side, by 2036, we're going to be short almost 1 million healthcare workers in the United States.
It's gone by a lot of different names: algorithms, machine learning, predictive analytics.
To me, the future is one that's based on standards which will evolve to meet our needs. It's based on using AI.
Let's make healthcare better together, right?
Welcome to the Next Orbit podcast, where connecting healthcare's data is the next frontier. We take you inside conversations with policymakers, healthcare leaders, disruptors, and visionaries who are pushing boundaries in a system that resists change. Explore how modern technology can remove barriers and improve care at scale. It's about ditching inertia and building smarter. For insiders, innovators, and anyone ready to navigate what's next, this is your launchpad. Here is your host, Ben Wade.
Hi, welcome to another episode of the Next Orbit podcast. We have a really exciting episode today. My guest today is a 30-year healthcare veteran. He spent the first half of his career leading high-growth commercial teams for two of the largest healthcare IT companies across ambulatory, acute, and post-acute care settings. In 2011, he joined a VC-backed specialty EMR startup and led them to a 9-figure acquisition in just 15 short months, which would be the first of several exits he'd be a part of. Today, he serves as the Senior Vice President of BINGLI, an AI-enabled healthcare solution that powers clinical decision-making with intelligent patient assessments and care navigation. With that, please welcome Mike Lang to the show. Mike, thanks for being here today.
Oh, it's an honor to join you. Thank you.
Yeah, of course. And one other introduction to make this morning, please welcome my colleague here at Leap Orbit and co-host of the Next Orbit podcast, Mike Hunter. Mike is the health tech director here at Leap Orbit and supports our federal partners like CDC, the VA, HRSA, SAMHSA, and others. He recently published an article on AI's intersection with data and interoperability standards, which I'll post the link to. Please welcome Mike Hunter to the show as well.
Ben, it's a pleasure to join you, and it's an honor to get to be here with Mike.
So yeah, thanks for being here to both of you. I brought you here today to talk about something that's there's been no shortage of discussion on, but it's AI in healthcare. As you know, AI has had a really big year, and there's a overabundance of hype around it, to say the least, especially coming off the heels of two major announcements: America's AI Action Plan in the summer, and then the $50 billion rural health transformation that just released, 2 weeks ago. So a lot of hype around AI and in healthcare, but it's been used in healthcare technology for a very long time. And I think it's gone by a lot of different names: algorithms, machine learning, predictive analytics, artificial neural networks. But some of these have been used in healthcare technology for decades. But with the new technologies like large language models, it's brought a lot of questions and concerns on the safety and efficacy of AI. And so today I'd like to discuss the different types of AI technology that are being used in healthcare. What are some of their strengths? What are some of the ways that they're used effectively and ethically? And what are some of the standards and governance that should be in place to ensure the safety and efficacy of these tools? I hope that's our listeners can take away a deeper understanding of some of the different types of tools being used and maybe breathe a little bit more confidence into the consumers. So Mike Lang, you've had a long career. You've seen the development of some of these different AI tools, and maybe you could share with the audience some of the ways that you're leveraging AI there at BINGLI.
We operate in a space where you have some rich clinical experienced companies in the market that I think are really living under the Hippocratic oath, but for AI, which is do no harm. And you see them leveraging the right tools. And then you see technology entrants that don't have a lot of healthcare experience saying, we're going to leverage LLM models for everything. And I think we're all aware that LLM models, for example, are not always going to give you the same answers when you put in the same variables. So it's really important for companies like BINGLI that we leverage the right tools in the right settings. And the best way to kind of explain what we do is we do fall under agentic AI, which some people call that the workhorse of AI. We also leverage ambient AI listening, which is, in my opinion, again, with 30 years, it's kind of the next iteration of Dragon or digital dictation, but a lot smarter. So what we do, and maybe using an example would be best, but we use LLM models to kick off a lot of our clinical workflows. They don't power our clinical workflows, but they kick them off. So capturing the patient's story, you can leverage LLMs very effectively and ambient AI technology very effectively to capture that story in a way that used to require a lot of people, the nurse, then the doctor. When physicians made a little bit better reimbursement, there was a scribe. Oftentimes we've converted our most expensive resources to scribes. So where AI can step in that process is capturing and documenting that story without human intervention. Now, another example would be when we kick off like a triage call where we're trying to figure out what's going on with the patient. We can leverage LLMs to convert a patient's "my tummy hurts" to abdominal pain. Now, I'm not creating the actual ICD-10 or converting it to SNOMED based on the LLM, but I am converting unstructured data to somewhat structured data. Where it's really important not to use the LLM is once I enter into that clinical workflow for abdominal pain or sore throat, strep, etc., is that everything that guides my workflow from there must be deterministic. And deterministic, I'm going to steal from an article that I read. Deterministic AIs are different from LLMs, in this case, in 4 different ways. I'm going to glance down real quickly because it's so well written. But deterministic AIs ensure consistency. That means whenever I put in the same variables, I get the same output. And in medicine, it's critical that I have consistency. The other thing that it does is it's auditable. So if you can imagine, if LLMs create hallucinations, that means that the work it's doing to come out with the different outcomes, nuanced in many cases, are not really auditable because they change in each output. And then regulated workflows. So deterministic models are often regulated. So in like nurse triage, BINGLI does nurse advice lines, nurse triage. We leverage Schmidt-Thompson protocols, which are the gold standard. And that means for every sore throat protocol, we're going through the exact same questions. Now, where there may be nuanced is based on demographic, socioeconomic, social determinants of health. Those may impact the way and what we ask, but ultimately the clinical protocols are not going to change. They're regulated. And then finally, when you're leveraging deterministic AI, it's much more scalable than LLM models where you have inconsistent outcomes. So those are the 4 areas that really, in my opinion, define not only the value of deterministic models, but the critical nature that deterministic AI has in clinical evidence-based outcomes. So again, we use LLMs, but we use it in non-clinical outcome-oriented workflows. And what's crazy is we'll use LLMs to help us build deterministic models because it's great at capturing lots of data and bringing evidence into clarity. And then after we go through the clinical outcome, we then may use LLMs to actually go into the deterministic model and give a report on how we came out with the outcome. So I know it's nuanced, it's complicated. We live in a different day than when if then was the only thing we really used in EHRs, etc., or dumb data documentation. So it's really exciting. But I do caution people to be very careful about looking at just AI for the sake of AI. The final part of deterministic is we publish all of our algorithms. And that's critical because in the world of medicine, physicians, nurses are used to peer reviewed documentation. So by publishing our algorithms, we give that extra layer of comfort for doctors and nurses on what's actually guiding the recommendations we provide. But we believe in human in the loop, and that is that nurses and doctors are still critically important to the end result. Algorithms can support them and reduce their burden, but they're the experts, and let them operate and provide the care that the patient needs.
That's great. Could I jump in for a minute, Ben? I had some thoughts on this, and I just wanted to say when it comes to what you're doing at BINGLI, Mike, I think there's a lot that if you're either a product manager or you are considering kind of purchasing a solution that you've said that would be important for people to keep in mind, because AI first is an important movement, and I think it's showing some great improvement. How we're reducing the burden, which has been a problem for many years now on providers and the care that they're giving. I like the distinction you made between deterministic and non-deterministic, and I think I want to just kind of, I guess, re-emphasize that, because I do see a lot of people who are first getting into AI because of the explosion of these generative models, the large language models and others, and saying, okay, this looks like it can do all the things that a human being can. And one of the things is it doesn't. So people need to be aware that it does human-like things that we would accept, but it doesn't necessarily do human smart things like a really well-trained smart human would, not without a lot of extra training beyond what you're going to see in the normal kind of chat GPT and other models. And so I bring that up because I'd also like to know, you've been working with this for a long time. What are some lessons that you might share for somebody who's either considering, like I said, a purchase, or is looking at an internal build and saying, how do I do the right things or pick the right tools?
Yeah, maybe this is going to be a mix of objective and subjective response. Subjectively, we are in kind of there's an element of the wild, wild west that we're in. It used to be when I was at McKesson or GE, you would want to make sure that vendor had been doing what they were doing for 10 years and that they had hundreds of implementations, that their interoperability was built out for thousands of different systems and installations. So couple things to think about. Most of the impactful AI that is available is still being presented by earlier stage companies. So you have to look at that criteria a little bit, not loosely. If you want technology that is truly transformative and clinically sound, you're going to be looking at earlier stage companies. So just keep that in mind when you're evaluating. The things that you ask of the vendors are not going to be, give me 100 customers that are using us, but rather tell me about your modeling. Where did it come from? So like BINGLI has been around since 2017, and building evidence-based AI modeling does take time. So you do want to make sure that the AI modeling is based on sound evidence-based principles, and like our nurse triage, clear protocols that are accepted by the industry. So you're going to tweak the questions you ask. The other thing that I think is critically important, and maybe some people will disagree with this, and that's fine, but if I was a CIO, chief nursing officer, or CNIO, CMIO, all those C's, I would want to look at the ethos or the philosophy of the founding principles of that company. And I would want to make sure that it was a clinically rich organization that was leveraging AI and technology to solve real world problems based on deep experience in being in those workflows. I would be much more cautious of technology companies that are entering into the healthcare market and saying, this worked great in these other industries. Now let me bring in this technology. It does not mean that that technology is bad. It just means that they have a much greater barrier to entry in understanding the true pain points. If you're developing, like we have a differential diagnosis, which is there to support physicians, you better have physicians on your team. I would look at the current market, understand that it's fragmented. It's a little bit of the wild, wild west, but there is incredible technology out there. And I would just make sure that there's deep clinical experience, that the AI modeling that you are potentially going to adopt in any of your workflows is evidence-based and published. So does that kind of address the question? Or
Yeah, very much does. And the only thing I'd kind of emphasize from what you've already said, and that I think you brought in here, is the fact that if you're doing that, you talked about the importance of human in the loop because we are looking at early stages. So some ways that you make up for essentially that experience, long history of experience, is to have people who have that experience and that knowledge and looking at it, and to have, as you said, like proven best practice and published work that shows that these algorithms are the ones that are in use today and why they are effective. So I really agree with what you just said, and it brings me to something that I'm gonna call out a little bit to my own paper and to some of the discussion we had, which is really around the idea of ontology being so important. And so that's one of those areas where standards are going to continue to matter. And human beings that understand what that ontology is in an organization are, in essence, kind of the human standard that you need to build these other tools around, in addition to the standards themselves. And so I really see, again, to me, the future is one that's based on standards, which will evolve to meet our needs. It's based on using AI in a way that enables the people who have the wisdom to do the work effectively and efficiently, and hopefully with minimal friction in their workflows and in their interactions with the patients and the people that they care for. And I think we're moving in that direction, and that LLMs are a part of that. As you pointed out, they seem to provide a nice interface between human beings and systems. And that if they're used that way, they can be very effective. But if you try to use them in other places sometimes, like you talked about using them for I'm assuming I should say training, model training and data and that's needed there, that makes a lot of sense. But if you try to put them in the wrong place where they're going to hallucinate and do something strange, you could end up like some of these. I just recently saw this morning that one of the large consulting companies has to pay the government of Australia several $1 million because the AI hallucinated in one of the things they produced for them. And so you've just got to be aware that's always a risk, and don't put it in a place where it'll do that. In healthcare in particular, it's not, we have to pay $300 million or whatever it was. It's, someone's life might be lost.
Mostly I love LinkedIn. But there was an article by a doc that was talking about an example of kind of this, where a family member was getting critical care, and they got a call from the husband or the son or a family member. Said, I just look at the labs. There's elevated enzymes in the liver. Clearly there's cirrhosis or there's liver damage. And it was because they went to WebMD and they entered in some symptoms and it came back with X. And then the doctor had to explain, well, actually, based on the critical care element of their visit, they had certain labs that were abnormal, but it was normal for them to be abnormal given the situation and the treatment they were receiving. They didn't have any history of elevated or abnormal liver function or anything like that. So we also have to be very sensitive when we talk about human out of the loop, or the physician or the nurse out of the loop. We end up with hypochondriacs. We end up with patients that believe that they're the physician, and it causes further strain on our system. So although we are digitally patient facing, when it comes to interpretation and reviewing elements, we still really believe that you want a nurse or a physician. Symptom checkers can be great, but there's a lot of false positives. And unfortunately, then it deals with the major issue that we just kind of deal with in general is mental health then gets impacted, because now I'm worrying about all these things. So BINGLI can provide solutions directly to the patient, but we believe that we will continue to believe that having physicians and nurses in the loop as the experts, as the clinical guides, is going to be critical.
So Mike and Mike, we got pretty technical there. I'd like to just bring us back to some utilization cases and maybe share with our audience some ways that this is actually impacting patient care.
BINGLI is a global company, so these are going to be a mix between European use cases and US use cases. The first one I'm really excited about. We all know mental health is a challenge, and having behavioral health comorbidities impacts outcomes, recovery time, things like that. We're being leveraged European market to actually better detect ADHD in adolescents. And left undetected, it can have a significant impact on quality of life. And but we're able to leverage our intelligent intake forms, for example, that are clinically and AI guided to better detect ADHD, which once you get that under control, it impacts the parents, the children. It's just really important. The other thing we're doing, and this is kind of getting into the clinical trials, clinical research realm, but if you're familiar with clinical trials, most of them are behind on their sample, getting patients to sign up. The inclusion and exclusion criteria is very difficult. Oftentimes it's a very human focused effort, and it takes way too much time. So we're being leveraged to actually better identify rare disease. Again, leveraging our clinical evidence, we're able to spot things en masse more easily and more efficiently than if people have to wade through that same information. We support nurse advice lines. We're working on a particular opportunity in the federal defense space where you can imagine our servicemen and women are calling these nurse advice lines all the time. We can be that clinical intake prior to going to a nurse or to a physician, which allows us to use our finite resources more effectively. On the clinical side, by 2036, we're going to be short almost 1 million healthcare workers in the United States. So we have rising demand and we have stagnant supply, and we're going to continue to deal with this gap unless we leverage digital health, AI, etc., to fill in the gaps. So on the nurse advice line, for example, we leverage our integrated Schmidt-Thompson protocols, and we're able to do a lot of that administrative burden, but 30 to 40% at least, prior to that patient then getting on with the nurse. So the nurses are able to almost double their productivity on the number of patients that they can encounter, and they're doing it with higher quality, with standards ensuring consistency in the outcomes. We do know that burnout is significant. In rural health, for example, it's over 50%, but burnout doubles the risk of adverse events. So if we're in all of these workflows reducing burnout, because administrative is, I think, number one or number two. I think EHR documentation and then general administrative are like one or two. They're in the top three. So if we can reduce that, we objectively improve outcomes. Is that helpful?
Absolutely. And, just got me thinking. I think we focused a lot on the clinical and administrative burdens that we're trying to alleviate or reduce. But what about revenue cycle? What are the applications for AI and revenue cycle management and claim adjudication?
Yeah, thanks. In 1996, my training started with posting EOBs in a Unix-based practice management system, so I'm very familiar with it. What's interesting is that everybody knows denials are going up, complex claims are going up, and insurance companies are absolutely leveraging AI. In many cases, there have been documented instances where AI is actually causing some of these denials or initiating some of these denials. So one of the things that we can do, first of all, with eligibility verification, documentation on the billing and patient access side, AI is a perfect tool. But the way that BINGLI kind of intersects with revenue cycle, which is something that other organizations that are solely focused on revenue cycle will do as well. But we can now take exactly how we came up with that diagnosis that is being challenged by the payer, and we can give them the evidence-based standards that were used in order to get to that diagnosis. Whereas now the physicians are in large part sending their SOAP notes to justify the claim that they submitted. Now we can augment that physician documentation with evidence-based standards that are just widely documented. And so we believe that BINGLI, and more importantly, other organizations focused on revenue cycle, can help ensure that physicians get paid what they're deserved. And hopefully we can reduce the administrative burden on the revenue cycle side a little bit at BINGLI by providing better documentation and rather than just the canned normals that became very prevalent with the adoption of EHR canned documentation. Now we have richer and more evidence-based documentation that can be submitted. But there are just great companies out there, obviously.
Well, Mike, that's really interesting and exciting what you're talking about. And I'd love to see if you've got some things you can kind of show us what it looks like in the real world. I'd love to see some of that.
Yeah, well, I would be happy to do that. And as any good 30-year veteran will qualify, this is only one. I'll show you something that is only one workflow. So I'll tee it up real quickly. This is I think it's a 3-minute video, and the workflow that it's capturing is Mike Lang calling up a nurse advice line. So I'm actually going to be speaking with a nurse, a triage nurse, or a nurse advice line nurse. And it is going to be leveraging ambient AI to capture the entire encounter. And the next thing that it's going to do in capturing that entire encounter is leveraging LLMs. It will say, oh, I heard this. Here are 2 potential assessment forms that are relevant based on what the patient is saying. So it's bringing that up for the nurse, and the nurse then goes through the clinical deterministic set of assessment questions based on that chief complaint.
How can I help you today?
Hey, Sonia, I'm calling because I've had a really bad sore throat. It hurts a lot when I swallow, and I've got a fever.
Well, I'm sorry to hear. Do you mind if I ask you some more questions just so I can understand what's going on and help to decide on the next best steps?
Yeah, of course.
Could you tell me when your sore throat started?
It started yesterday afternoon.
You said it was really bad. Are you still able to eat and drink?
I can eat and drink. It just hurts, especially when I swallow.
Do you have a cough, a runny nose, or any other symptoms to go along with it?
No cough or runny nose, just the sore throat and fever.
Okay, thanks for that. Now, you mentioned the fever. Have you had a chance to measure it?
Yeah, I did this morning. It was 105 degrees.
Okay, I've noted that down. Listening to you speaking, it doesn't sound like you have difficulty breathing. I don't hear any whistling or wheezing noises. Would you agree with that?
Yeah, I don't have any trouble breathing.
Are you able to open your mouth completely?
I can definitely open my mouth.
Okay, thanks for that. So just to confirm, you're able to swallow liquids and you're able to keep them down.
That's right. I can swallow water.
Okay, that's good to hear. And is there anything else you'd like to share?
No, that's it. I don't have anything else.
Okay, thanks for this. So based on what you've told me, you have a sore throat with a high fever and no cough or difficulty breathing. You don't have any alarming symptoms at the moment, but I would say the guidelines recommend you be seen by a healthcare provider soon. I'd advise you to contact your primary care provider's office right away to schedule an appointment. If they aren't available, I would advise you to go to the ED so you can get evaluated today because it could be a bacterial infection.
Yeah, okay, that makes sense. I can do that.
In the meanwhile, do you mind if I share a couple of things to maybe help you self-manage at home?
Oh, that would be great.
Okay, perfect. I can send this along in an email just for ease, but in the meanwhile, while I have you on the phone, you can actually take some acetaminophen or ibuprofen for the fever and pain if you normally use those. I'd also recommend you drink plenty of fluids and gargle with warm salt water, and that might help with the sore throat discomfort. That said, if at any point you have trouble breathing, you can't swallow, or your symptoms worsen, please definitely call us back or go straight to the emergency department.
Okay, I got that. That will definitely help me figure out what to do next.
I hope this helps, and I really hope you feel better soon.
Thanks, Sonia.
Not a problem.
Now, the other scenarios, the nurse on the video or the sound is incredible. You can actually imagine us using our voice agent, which we also do. So a patient calls a nurse advice line and they speak with a voice agent, a non-nurse, to do the clinical intake. And then once that's completed, it goes to the nurse to review everything that was shared. And then they determine whether or not they go to the ER, the urgent care, a virtual care visit, so on. And then finally, this can be digital front door oriented, where they're just sent a chat like experience where they say, my tummy hurts. We convert it to abdominal pain and bring them through the appropriate triage assessment. And then we either create a triage score or we can then send a differential diagnosis based on that clinical intake. So this is one workflow. And the other thing, just we know that ED wait times are just, they're a burden to every health system I've ever spoken to. 4 and 5 hour wait times. And the challenge is that we are oftentimes communities are using the ER as a primary care doc, because now if I'm sick and I try to call my primary care doc, me personally, it takes 15 to 30 days to get an appointment. So we're either going to the urgent care center or we're going to the ER. And one of the other ways to leverage this deterministic kind of triage is, instead of having to put an extra ER doc in the waiting room, leveraging technology like this to reduce the burden. So just wanted to kind of put those pictures in your mind on how the different workflows might present themselves.
That's really interesting. Before you jump in, could I just make a comment? Because I heard you say a couple of things that I think are important. A few things, actually. One is that you're going to show kind of one modality for using your technology here and similar technologies, but it really supports kind of, the continuum, I would say, where for this kind of a service, you could have either a trained nurse, a voice agent, as you said, as a different kind of modality, or you could have a chat-based interface, but the technology behind it is going to continue to enforce the standards and provide the kind of guidance that leads this this phone encounter essentially into the appropriate direction. And I think that's really important. The other thing that you said that is, I think, shows a lot of holds a lot of.
Yeah. So thanks for letting me share that. A couple things that I just want to point out. The ambient listening is incredible. And again, I started selling IBM MedSpeak back in 1999, I think it was. And then Dragon, and you still had to, in the EHR, still click on each field to get it. And then you start dictating. But our nurse triage, the reduced burden or administrative burden is at least 50%. All of that context that was shared in a non-BINGLI workflow is being documented manually by the nurse. Now, if you can imagine, no matter how good people are with multitasking, there have been study after study saying nobody can truly multitask. So if I'm having to document while I'm on the phone with the patient, I could miss something. But now I am just listening to the patient. I can be empathetic. And we actually say what we do with BINGLI is tech empathy. So we're developing technology with a strong empathy towards all of the stakeholders involved. But you saw the ambient data being captured. Then you saw the LLM take that ambient data and recommend a throat, or I think it was fever. And now that's where the nurse in the loop said, oh, it's better to do the sore throat. That's the primary, the chief complaint. And then the system brought up the right protocols, which are all deterministic. And then all of that information, which I didn't say, is number one, BINGLI can consume information from a third party. So if we had existing medications, other data, that would obviously help us even more refine the questions that we asked. One example is, we're not going to ask my wife if she's had a prostate removed. You're not going to ask me if I'm pregnant. Right. So those are just things that the LLM and the deterministic model can determine, versus a lot of people, when we talk about clinical intake, they say, well, I'm already doing digital intake. And what they mean is I'm sending 4 different PDFs that oftentimes still have all of the same header information that's required, and it's static. So I just ask everybody the same questions. AI is allowing us to really tailor that to the patient and the provider experience. And then finally, we can send this information to EHRs or other data environments. And we can do that either through the FHIR standard, custom API, HL7, JSON, and then all of the data that we're using in a structured way is SNOMED. We're creating the SOAP note automatically. We leverage the ICD-10s, et cetera. And one of the things we're now just releasing, I think this month or next month, is we've integrated with order sets from a third-party company. So in ER triage, for example, what typically happens before the patient's seen by the doctor, the RN actually puts in the orders, like an EKG or X-ray or whatever it is. So now we're able to marry that in as well. So just a lot going on. And one of the things that I've been saying for a while is it takes a lot of work to make things look elegantly simple. And I think that's what we've accomplished with BINGLI.
We've talked about some technical modalities of AI today. We've learned a little bit about BINGLI and what you're doing there, but I'd like to shift gears for just a minute and just to learn a little bit more about you, Mike, as a person. What are some of the things that drew you to BINGLI and allowed you to stay in healthcare for 30 years? And what are some of your interests outside of healthcare when you're not building new healthcare solutions?
Yeah, thank you. One of the things that I get to do is work with good people. So, I help a lot of companies, and BINGLI is the company that I've chosen to help now. And it's because the co-founders, Tom and Pete, are motivated by altruistic goals to improve care, reduce burden, all that, but to improve care. And to really make sure that both the physician and the patient experience improves. That's important to me because in 2015, I went from a pretty seasoned healthcare technology person who I've always cared. I've always believed integrity is kind of my calling card, which dictates everything and how I do it, why I do it. But in 2015, the intersection of my career and my family life collided. We had a family member that had an overdose, and I had to walk through. He survived, but the ensuing 2 years allowed me to see the incredible aspects of our health system and the severely broken aspects of our health system. One example, I showed up at this recovery unit. This is like a 30-day program, sobriety program. I got there in a 911 kind of situation, just been discharged from the overdose, and they're doing an intake, and they said, by the way, you have to give us $30,000 up front. Now, as a father in this situation, didn't matter. I knew that I couldn't take them back where they were, so I had no choice. But that's a big communication breakdown, and it's because insurance companies don't approve these type of claims quickly, forcing these recovery units to require payment up front. Good or bad, it is what it is. And then denials. We went into a 1.5 year journey of dealing with denials for care that was critical for, in the moment, his survival. So unfortunately, I experienced the brokenness of the system at a time when finances and denials are the least of your concerns. You're worried about your child. At the same time, I experienced the best of healthcare. People that were wholly committed to saving, in this case, these adolescents suffering from an aggressively evil disease. And I got to see these people giving everything, despite the administrative challenges that they were experiencing from those third party. I quickly transitioned from looking at healthcare as a career and how it would profit me and my family so I could, take care of them. So the transition was a priority of profit converting to purpose. So I live and breathe and work in healthcare right now based on my purpose, which is to leverage all of my failures and successes in healthcare and bring it to bear to improving our healthcare system. In whatever niche area I'm in, I'm going to do everything I can to make a difference for that next set of parents and patients that are experiencing a broken system. I believe with AI and machine learning and the tools that are now at our fingertips, that we can have a significant impact on care. So that's what motivates me.
Mike, first of all, thanks for sharing that story. I think some of the best innovations rise from founders and executives who have a strong reason why they're in healthcare, aside from making a living for themselves and their families. So appreciate you sharing that. And for any of our listeners who want to get in touch with you, Mike, or maybe learn a little bit more about BINGLI, what's the best way for them to reach you?
Yeah, so just send me an email. It's michael.lang@bingli.us, BINGLI .us. Go to bingli.us. I think request additional information. We've got some white papers. I know a lot of innovative companies are very secretive because they're afraid that their secret sauce is going to be exposed. And we're trying to get as many white papers and evidence-based kind of materials out there. But set up a demo. Likely you'll meet with me or one of my colleagues, and let's make healthcare better together, right? So, yeah.
Well, awesome. I really appreciate you joining us, Mike, today, and all the insights and that you've been able to share with our listeners. And this concludes another episode of the Next Orbit podcast. We'll see you on the next one.
Hey, thank you so much. Have a great one.
The Next Orbit podcast requires more than a conversation. It takes action, research, and collective wisdom. If today's episode resonated with you, we'd love to hear your insights. Join the conversation and help us shape the future together. We'll be back with more stories, strategies, and real-world solutions that are making a difference. In the meantime, be sure to subscribe, write a review, and share it with someone you think would benefit. Thanks for listening, and we'll see you on the next episode.